But no, it definitely, like, I noticed, like, when it gets started, like, 4 o'clock, like, I'll turn it on.
You need 9.
Yeah.
I mean, you might be on time, but yeah, last year.
All right.
Yeah. Pay for this an alternate email list.
Yeah, they do. They always come in. They just had a morning class, right? I mean, walking and dropping.
Hi, Hunter. Good evening and welcome. Thank you all for being here. Welcome to the Case Western Reserve University School of Law. My name is Aisha Bell Hardaway, and on behalf of the Social Justice Law Center, I am honored to have our students, the broader community, fellow lawyers, and elected and appointed officials here with us today. As director of the Social Justice Law Center, please allow me the space to briefly describe our center's core function. SJLC serves to ensure that students at our law school interested in understanding the contours of American inequality have access to top-notch legal educational offerings and experiences. For far too long, law schools around the country have failed to recognize the inadequacy of a legal education that ignores the ways that inequality is baked into the brick and mortar foundation of America's legal structures. The Social Justice Law Center aims to meet the curricular interest of law students at Case Western Reserve University, motivated to understand how injustice has been central to the justice system that is often romanticized and lionized in popular culture. The work of SJLC is of great professional importance to me, and I'm grateful for my colleagues and student leaders who do this work with us. Eric Seiler, who's not in the room, but please extend my gratitude to him. Michael O'Donnell and Alexandra Mendez Diaz, leaders of SLIC and the Disability Law Society, forgive me, and members of our co-event sponsors, the Student Legislative Initiative of Cleveland, Black Law Students Association, and the Disability Law Society. Thank you all for your engagement and your efforts towards this work. So we're all here today for a panel discussion entitled Putting Health First in Mental Health Response. And I'll moderate this panel discussion where our guests will share valuable information and insights on how communities can care for the needs of our fellow community members when they're experiencing mental health crises. This issue is personally of importance to me, and I'm honored today to have with us my classmate's mother, Miss Anita Arrington Bay, who's here. Her son, Omar, and I were in middle school homeroom and high school homeroom classrooms together. He was, I say to people all the time, the kindest, most gentlest, humble man that ever walked in a high school, I promise you. He always made sure that I was taken care of. He opened doors, he pulled out chairs, he checked on me in ways that most high schoolers don't have the presence of mind to do so. And Omar was taken from us in June of 2013 following being incarcerated during a mental health crisis with the Bedford Heights Jail, at the Bedford Heights Jail. And so I'm honored to be here. I'm honored to have you with us, Ms. Arrington Bay. And then this event, as many of you have seen, is also designed in recognition and commemoration of the passing of Tanisha Anderson. Tanisha Anderson is a neighbor of this law school. Her family lives on Ansel Road, and her uncle came on our campus a couple of years ago, and somehow, some way, someone pointed him in my direction. He has been tireless in his energy and his effort to work to understanding what could be done different and better to avoid having people like Tanisha and Omar lose their lives when they're in desperate need of help. And as a result of his work, he has partners here on this campus and partners at Cleveland State University and all throughout the mental health community who are grateful for his grace and his engagement and his willingness to have us work alongside him. Mr. Anderson, could I ask you to come down and share a few words, please?
For coming. She pretty much said it all for me. But yeah, 2 years ago, I decided that maybe it was time to move forward with the intentions of trying to find out how police can better respond to a mental health crisis. 9 years ago, we lost Tanisha, and a couple years ago, we lost Tanisha's mother. And watching her take her last breath, I promised her that it wasn't over. And so I didn't know how I was going to do it, but I do know that universities and colleges are very powerful. And so I was led here. I wish the lady that walked me over, I'll never forget the day I walked on campus. She was an older woman, and she was almost to her car. But I was on the other side of the campus, and she generously walked me all the way over here to the office. And from that day to this day, we're still working. We're still working. So I appreciate everyone for being here, and back over to Professor Aisha Hardaway. Thank you.
We're grateful for you and your family, Mr. Anderson. Thank you so much. For our panelists, I want to just take some time to give some brief introductions. First, we have Bree Easterling. Bree Easterling is a social justice outreach and organizing specialist at Policy Matters Ohio. Bree has worked to develop a non-police care response for people in crisis due to mental health issues, substance abuse, being neurodivergent, or being unhoused. They have a rich background in social justice reform, community engagement, and grassroots activism. Bree is a disabled Air Force veteran and worked as a Veterans Service Officer and Outreach Coordinator for Cuyahoga County Veterans Service Commission prior to their fellowship with Policy Matters. Bree continues to connect policy to people and people to policy with a focus on care response, mental and behavioral health, fines and fees, and eliminating collateral sanctions. Welcome, Bree. Next, we have Corey Elaine Schleifer. Corey is a queer community organizer who's with firsthand experience in the crisis response available to Cleveland residents. She specializes in advocacy for marginalized healthcare, particularly behavioral and reproductive care. She is one of the co-founders of REACH, which stands for Responding with Empathy, Access, and Community Healing, Cuyahoga County's grassroots coalition advocating for expanded crisis response services. Corey is appointed to the Cleveland's Mental Health Response Advisory Committee, where she chairs the Community Engagement Subcommittee. She is also the organizing director at Ohio Families Unite PAC. Welcome, Corey. And last but not least, we have Josiah Quarles. Josiah is the Director of Organizing and Advocacy at Northeast Ohio Coalition for the Homeless, NEOCH. Is it NEOCH? Yeah. NEOCH, a street outreach program, provides relationally based, trauma-informed street outreach services. Josiah has a background in grassroots organizing, public speaking, education, sports-based youth development, and multimedia arts. Social justice and the liberation structure have been at the heart of many of Josiah's professional and artistic endeavors. He views two-way education, community-based solutions, and decentralized power building as fundamentally essential to challenging the politics and policies that have codified the oppression and disenfranchisement of so many. Josiah also helps organize #CareForCleve, which is a coalition-based campaign advocating for non-police response to mental health crises in Cleveland. Welcome, Josiah. So hopefully this mic will be on here shortly. Is it on? Can you guys hear me okay? I know I'm loud enough, but Rob, tell me if it's not picking up enough for you. Thank you. So thank you guys all for being here. I think the best and the easiest way for us to do this is maybe for us to have a moderated discussion. So that's what we agreed to do. That's what we're going to do. And if each of you in turn could help describe for us what brings you to this work, why is it important to you? Bree? Yeah.
First, I just want to say thank you for having me. Yeah, it's an honor to be here. Thank you, Mr. Anderson, for allowing me to be here today. Yeah, what brings me to this work? From from a professional perspective, you know, it will obviously be my work at Policy Matters Ohio, being focused in like criminal legal reform, addressing issues within the criminal legal system, and how that intersects with so many different other social economic issues. But from a personal perspective, which I feel like is greatly more important than the professional, is my own lived experience with behavioral health crisis and the community that I'm from experience with behavioral health crisis, and not just having that experience with behavioral health crisis, but witnessing and experiencing it being criminalized, which is, you know, what has led many of us here today is the criminalization of behavioral health crisis. And so, you know, I vowed to myself and to my community to work to decriminalize behavioral health crisis. And so that's what brings me here today.
Thank you.
Yeah, I just want to echo the thanks to everyone for being here. We are all experts in this, and we are all participants in a movement, and the movement requires every single one of us. Everyone has something to give to this. So my name is Corey, my pronouns are she, her. I'm a queer community organizer, and one of the things that is very correlated with trying to do good community work for the queer population is that mental health and trauma are always issues. They are always in the room with us. And I spent a long time doing other work and knowing that, and then my own mental health popped off. And at the end of 2020, I had a series of searing experiences with the Cleveland Police Department, and put my foot down and said, we're not doing this anymore. And so I am very grateful also to my two co-panelists and to everybody that we work with and every member of the Care for Clee coalition, because we are inching closer to not having to do that anymore.
Josiah?
I say, yeah, I guess I'll kind of take the two-pronged approach that folks have been given. And so from my family, my grandmother was involuntarily committed, and you know there was abuse in the home, and I've had multiple friends and family members who have either failed in accessing or have been able to access, and the disparate impacts of accessibility and cultural competency and just the barriers that exist between people and the care that they need really resonated with me. And I had my own experiences personally with officers confronting what was honestly a crisis for someone, and indirectly violently interacting with family members, including myself, right? And so personally, that's kind of where I came into this, and intellectually breaking down what the carceral system does to communities and how we can reshape that and look at and be generative in how we keep each other safe and whole and healthy. So this model I came in contact with it, and it really spoke to a lot of different things that I wanted to be involved in. And professionally working with an unhoused population, there's a lot of trauma, there's a lot of instability, there's a lot of crisis mode, fight or flight. It's everywhere, and it's hard to be able to use that front part of your brain, right? So we have to hold each other in that moment and then walk forward. And that capacity, I think, is what the call is today.
Thank you each for sharing your perspective and the space in which you come to this work, the perspective in which you come into this work. I think it might be helpful for all of us if you shared a bit about sort of what care response is as a baseline sort of foundation to our conversation today. If we could talk a little bit about care response, and I might, yeah. I've left it. That's how we do it. I just get it. Thank you. Thank you.
So behind us on this nice screen that was provided for us today, we have a basic and simple kind of explanation for the type of crisis response that we have in our community. So we basically there are 3 models. One of them doesn't exist here, and that's why we're here. The first is the cop response. So I'm sure a lot of folks have heard the saying that if all you have is a hammer, everything is a nail. So that's kind of that's the metaphor here. And it's not about any officer. It's just kind of what the role is. And so that's what we have. And we have the ability to train officers through CIT, and that occurs across the country and here in Cleveland. But that is just a cop response, just a police response. So they may have 40 hours of training, but they certainly don't have years of lived experience and work in the field specifically around some of these challenges. And then I'll leave you with a co-response.
Yeah. So then the co-response is, a cop or a law enforcement officer that is paired with either a social worker or a non-police specialist or a healthcare worker rather. But oftentimes, from what people have experienced is that even with that pair, police typically have to go in and what is called assess and kind of clear the scene prior to the social worker stepping in to interact and treat the individual in crisis. Lastly, we have the care response, which is what we're advocating for right now, which doesn't involve a police at all, but rather it involves a trained mental health professional that could be paired with like a peer support specialist, EMTs, nurses, but the overarching thing obviously is no police involvement whatsoever initially.
Yeah, and to be more specific, also like there is co-response here. We do have co-response in our community, and it has been, for several years now, and it's continuing to expand. But it's really kind of just now being like operationalized in a way where you could actually receive a co-response in real time. So that's just beginning. And there is no care response now in our community. We do have mobile crisis, but it's certainly not necessarily available in a crisis physically. And yeah, so it's more of a follow-up in a phone call situation. What we're talking about is an actual first response to when there is a situation, whatever that may be. And we can get into a little more data with some of the later slides.
So maybe go to the next. And I should say to the audience, we are going to do Q&A at 1:45, and then also it's important for you all to know everyone's invited to the reception in Ben's place. I think I forgot in my opening remarks to say that, but there's food upstairs when we get done. Okay. So maybe it would be helpful if we could talk a little bit about how care response would be different than the 2 models that we currently have.
So as we saw, care response is a piece of a continuum, and it does not rely on police response. So there are some really key operational differences for how this type of first response program operates. So this is kind of a list of kind of what are the differentiators. So first, care response operates best under a community advisory body. There's lots of reasons for that, but one of the key ones is that it's new. it's a new program for us. Folks don't have experience receiving this kind of response. Folks don't have experience calling 911 and saying that they want this response. And so the community advisory piece is as much about just educating folks on how to access this service as anything else. It also helps us do things like know really granularly how neighborhoods are responding to it, or where peaks and valleys might be in usage and things like that. And the second key component is the ability to dispatch directly to 911. So when it was, cop, code, care, that whole continuum needs to be able to respond to 911 calls, because we have baked it into everybody's brains for decades and decades and generations that 911 is the number you call. And so we love 988. I'm not here to say anything bad about 988, and it is not a replacement for 911. And so when we're developing alternative first response structures, we have to make sure that they rely on the same communications infrastructure as every other type of first response.
Can I ask somebody to dig a little bit deeper into 988 for those in the room who may not be aware of what that is and why you referenced it?
Yeah, so 988 is a national mental health hotline. And so it's a very long, people have advocated for this for about 2 decades. NAMI National has been a major partner in this. And so it's developing the infrastructure for all of us in the country to have an alternative first response to the police for mental health crisis, because everybody in behavioral health, everybody in law enforcement knows that that's coming and it's needed. So 988 you can call, and I don't know if you ever called like a suicide hotline or the Trevor Project or a hotline like that, but it's the same kind of response where you're going to get probably a social worker or a crisis counselor who can hear you out, make recommendations about resources, make recommendations for you about your next step, but also just listen. And so 988 does kind of fill a service gap in that way. And so I would definitely recommend looking it up if you haven't heard of it before. Also, give it a call. They don't bite. And so you can kind of get to know what that response would be like.
So one of the third key components is including the certified peer responders, or otherwise like a peer support specialist. The importance of this is having a directly impacted individual or somebody who has had the experience of working with directly impacted individuals to be able to respond to that call. 2 reasons. One is the cultural competency to be able to interact with the individuals that are in crisis. And then 2 is just like having the interpersonal skills and the empathy that oftentimes comes from somebody that has also had that experience to be able to empathize with that person in crisis, which is very important when trying to de-escalate and re-regulate a person in a behavioral health crisis. One key example, because ideally, right, not even just those 2 things, but when we talk about having care or community care, or really looking out, or community safety and looking out for each other without the presence of police, a peer support specialist could be your neighbor. It's typically somebody that is from the neighborhood, that looks like the people who live in that neighborhood, or represents that neighborhood. And that's so important, right? Like when trying to address a person or a crisis situation. The first thing that comes to mind about that is like, for instance, if everybody, I don't know if anybody remembers the Alton Sterling incident, when Alton Sterling was killed in Louisiana, because ultimately he was called because he was selling CDs or cigarettes outside of the store, but everybody knew him in the neighborhood, but the police didn't. And so, when we think about like a peer support, and if they are the first responder, they are more likely to even know that person as them being their neighbor or somebody to de-escalate the situation, so they don't have to interact with somebody that they don't know. Another example would be there's in St. Petersburg, Florida, they also have an alternative response program. And it's called their program is called the CALL program. Now I can't remember exactly what it stands for, but one thing that really stuck out to me when we had a virtual site visit with them was that one of their, they call them navigators, their peer support specialists are navigators, and one of their navigators used to be a food delivery driver. And so like one of the reasons why they were so effective is because of their job as a delivery driver. They knew the neighborhood, they knew the routes, they knew the quickest routes to get to somebody. And so it's an invaluable asset to have when you bring in directly impacted individuals, when you bring in a peer support specialist to be paired to respond to those type of crises.
And I love to transition that to actually connections to like the services and the places to go and things like that, because not only do those people have an understanding of the neighborhood, but they're also then integrated into like what are the actual resources. So you have a person who you can talk to that also has that level of understanding, and also those personal relationships that they've built up through those systems, those contacts. Like, hey, I'm having trouble with so and so. Like, they're not getting an answer. What's going on? So that level of follow through and kind of like systems accountability is kind of baked into the cake. And so that's a wonderful thing, and having having that feedback loop continually, which was brought up kind of like the advisory board, but within even the processes of a program like this, the best practice is to continually have that feedback loop between the responders, between the places to go, so that everyone's in the families and those affected and interacted with, all of that becomes part of continuing to better the program and fit it for community need.
And one thing that I wanted to add to that before we go into this last component is that when it comes to health, like overall healthcare, and the racial disparities and the disconnections, right? It's oftentimes talked about it with regards to physical health, how language, right, like African American vernacular, can be like misinterpreted by the doctors, and oftentimes that leads to discriminatory practices and interactions with the physicians. The same thing applies in mental health care and in mental health crises. And so, that's why when we talk about like peer support specialists, it's so important to have somebody that's from that community, that looks like that community and speaks the language of that community, so that when that person is in crisis, they're not thinking about respectability politics. Like they're not thinking about, like how do I convey this professionally, or how can I translate this so this person that doesn't look like me can understand? No, that shouldn't even have to be a thought or something that needs to be done. What needs to happen is that needs to be addressed with having an actual person on the scene, on that team that can communicate and can understand whatever it is that person is trying to convey and communicate during that crisis.
I find that to be such an important point, right? Because so many of us think about that as we're choosing professionals, right, to provide services to us, right? I don't care if it's your accountant, I don't care if it's your doctor, right? I don't care, like as a Black woman looking for a therapist, I'm not looking for somebody that I have to translate my life experience to, right? And then work through sort of like our weekly or our bi-weekly appointments, right? And so those of us who come from a different place or have the space and the opportunity to be intentional about the services that we align, the folks that we solicit to provide us services or sign up to provide us services, right? How thinking about this model in such a way that aligns with what we all would normally do for ourselves anyway. Right, I guess is what Absolutely. I'm trying to say, right? Like, it's what everybody in this room would want to have the space and the opportunity to be able to do. Yeah.
Then wanted to go into the last component up here.
Okay, yeah, please.
Because I feel like it's equally as important as all the other ones. And so when we talk about like a program planning process that solicits and responds to the feedback of directly impacted community members, yes, because the community that is going to engage in this service ought to be able to have some type of pathway to critique or give praise to lift up this type of program. And oftentimes, in many programs, I'm sure a lot of us can name, or different initiatives throughout the city and things like that, there is such a lack of community input that that is ultimately what exacerbates the issues that program or that initiative may or may not be addressing. And I don't know if any of y'all to add to that. But yeah, I definitely want to lift up how important it is for directly impacted individuals or individuals that are accessing that service to be able to have a say and a voice in terms of what their experience has been like with the service, what can be improved, what can be improved, and what's working.
Yeah, it's about trust.
And I know that you all have been on the grounds doing a lot of this work and hearing from community about sort of what they would like to see. Can you share with us some of what you've heard? What is community, those that are impacted and in need of these services? What is community saying that they want to see?
Yeah, so I'll just touch a little bit on this is actually some details from the first portion of the survey, or directly impacted survey series that we, us at Policy Matters in collaboration with Reach, have been working on. So the first phase of the survey consisted of just exclusively engaging the unhoused community in Cleveland and seeing what their interaction has been with first responders. And so we extended it beyond law enforcement to also include EMT and firefighters. And that was done intentionally because of how they interact and how oftentimes all of them may show up during a crisis. And oftentimes the experience of that interaction with the first responders outside of police sometimes mirrors their interaction with police in a negative way. And so we wanted to hold space. We wanted to hold space for that. So with the unhoused community, we were partnered with NEOC. We received like just under 200 responses, and I don't know if you all can see that or read just some of the, we put some of those responses up there, or some of the quotes up there. One of the main ones that really struck us and that we included in the report was, this actually, like the part of the title of the report is "Talk to Me Like a Regular Person, Not a Criminal." And this is what somebody had experienced during a behavioral health crisis here in Cleveland. They felt like they weren't being humanized in the midst of a behavioral health crisis. And I do want to say that the responses received in phase 1 and even in phase 2. And so just real quick about phase 2. Phase 2 consisted of 5 demographics. The first one was people who have experienced severe mental illness. We partnered with Magnolia Clubhouse to receive those responses. Then we partnered with Stella Maris for people who have had experience with substance use disorder. We partnered with the LGBT Center to get responses for people who are part of the LGBTQ plus community. And then we partnered with University Settlement and Friendly Inn to get feedback from people who live in historically over-policed and underprotected neighborhoods. And the fifth component, which is the only one that is still pending, was a partnership with PEP, Positive Education Program, for the youth component. There was also a series of a few focus groups that were done as well. But I say all that to say that, like, there was an array of responses in regards to how people interpreted their interactions with first responders. The one commonality, regardless of how people interpreted their experience with first responders, is that when they came to their opinion on whether or not a mental health crisis should be responded to by mental health professionals, it was overwhelmingly yes. So, like, regardless if they had an okay interaction with law enforcement or EMT, or if it was really bad, or if they feel like they had a great experience, even regardless of the experience that they felt like they had, when the question came to whether or not a mental health crisis should be responded to by mental health professionals, it was yes. And so I found that to be pretty incredible and insightful. Yeah, I don't know if you had anything that you wanted to add just from your experience with NEOC.
Yeah, I mean, it was great to have. NEOC has, as a part of our work, a homeless congress, and so there are like community meetings held, once a month. One on the east side, one on the west side, and there's a leaders group that's outside of that that kind of like informs that and helps facilitate, and so some of those leaders were able to participate, and that is where a large number of the data came from. And again, I think that speaks to being able to understand a place and understand the people in that place, and being able to utilize that to have that trust effectually paid forward to something positive. And that's what this endeavor is really about.
And then real quick, I do have like just a few, cause for phase 2, we literally like just wrapped it up. I want to say within like the past couple weeks. We received a total of 578 responses throughout those the 4 demographics that I just mentioned, and I was able to pull just some of the basic findings. So for like the interactions, the leading cause of the interaction was physical health, and then the second leading cause was mental health as the leading interaction of what caused whoever the person was that was filling this survey out to be responded to by one of the first responders. In phase 2, even though we did in phase 1 exclusively focus on unhoused individuals, even in phase 2, the people who filled this out, it was over 50% of the people who filled this out in phase 2 had experienced homelessness. So even doing that one just based on unhoused people and looking towards a totally different demographics, homelessness still is the running theme. For age, the leading age range of people who interacted with these first responders was between 26 and 64. The second leading was 18 to 25. So you see, like, you have like this youth, like young adult populations that have the highest interactions with our first responders here. For race, the leading race and ethnicity was African American. The second leading was white. For the LGBTQIA demographic, so 40%. To be exact, but ultimately like almost half identified as being a part of the LGBTQ plus community. And for gender, the leading gender of who experienced interactions in this survey was 45% male, 43% identified as female, but over 10% identified as either trans, non-binary, or intersex. So over 10% of the people who filled this out identified as being gender diverse. And I feel like that's extremely telling, especially with the lack of acknowledgement that we have here in Cleveland for our trans and gender diverse individuals.
Thank you. I know we're getting close to our question and answer period. It would be, I think, helpful if we had a sense really quickly on what other jurisdictions are doing nationwide. I know you mentioned something about St. Petersburg, Florida, but if you have other examples that you'd like to lift up.
Absolutely. So one of the things I do at REACH is run an Ohio-wide alternative response roundtable, convening folks from various Adams boards, various agencies, basically the folks who are going to be hands-on as care responders. How are they building those programs? What are they learning? These programs are all less than 5 years old, so we have a lot of learning to do together. So I'm going to bring just two quick examples that come from Ohio, although there's examples nationwide. I think at this point, most of our major cities, especially the capital cities across the country, have care response. So I'll just delve into Cincinnati really quickly. The teams are made up of one behavioral health specialist and one Cincinnati Fire Department firefighter / paramedic. That's one person. All their firefighters are trained as paramedics. And they use City 911 dispatch. That's their communications infrastructure. And the ARC teams specialize in kind of this behavioral health service trajectory. So they do de-escalation, assessment, crisis intervention, transport if you need to go to a service or an agency, and also access to basic needs. And the other example I'll lift up is Dayton. Dayton is a relatively new program. They're about 18 months old now. Their teams are made up of social workers and counselors, so there's not quite that mental health expertise as we saw in Cincinnati. So these team members have experiences in things like victim services, children's services, and other areas of community response. The MRU does have its own hotline, so they have I forget their digits, but they have basically their own 988, and they can receive 911 calls. And they specialize in sort of the conflict mediation, de-escalation, and connection to services. And so the reason why we're taking these two examples in particular is that you're looking at kind of two different ways that care response can work. In Cincinnati, you're seeing that behavioral health bent. We're sending healthcare specialists for mental health calls. In Dayton, it's the same kind of methodology about non-police crisis response, but what they're doing is going to nonviolent family dispute calls. And both of those categories, by the way, aside from welfare checks, are the two highest grossing categories of 911 dispatch calls for our city. So what you're looking at when we look at Cincinnati and Dayton is two types of care response programs responding to two types of needs. We have both of those needs, so we have things to learn from both of those cities. And I'm happy to share more about any other city that you want to know about too. So.
Are we okay if we pivot to Q&A?
Yeah, I think that's
Okay, all right. So first, before we go to Q&A, oh, sorry, my bad. Let me just mind my business. No, there it is. One thing I want to announce for our students at the law school, we do have an embedded counselor. Here on the screen is the process that you all can go through if you want or need to make an appointment with that individual. Here in the building, there is an embedded counselor to meet our students' needs. I know that there are representatives from NAMI in the space. NAMI, I don't think I met you before we started. Anybody here? Uh-oh, I made a liar out of me. And so that's good. We can go straight to Q&A. And I know I saw one from Professor Flam. Did I see your hand? Good, you're good. Any questions, just raise your hand. We have a microphone. Zaid Noel with the Social Justice Law Center. Everybody meet Zaid. He is the program director of the Social Justice Law Center. Okay,
Thank you so much. Corey, it's Ann Flam. We haven't seen each other in person in a long time. My first question was really good timing because it was just in a vocabulary or a word that I thought you used in your last comment, that you said these two types of care responses between Dayton and Cincinnati were the highest grossing 911.
Grossing might just have been my not expert way of saying it. What I mean is that the three categories in which we have the most 911 calls come in any given period are check welfare, mental health nonviolent, and family dispute nonviolence.
Okay, that relates to my second question. So more of a high volume percentage. Okay, I was thinking grossing, meaning somebody's making money off this.
No, I'm
My
sorry. Yeah.
question, not surprisingly, is are these programs getting any kind of parity in funding with, buying police tanks and things like that? My background is in bioethics, and so the lack of parity in healthcare broadly between physical interventions and talk therapy or other cost centers within the hospital. Are we at 10% parity? Are we at 30% parity? Do we even think about it? Are these relying on volunteers? What are your funding approaches?
Can I hop in there? Okay.
Yeah, take it.
All right, so it's minuscule. If you want to kind of talk about like the entire health and human services departments and try to make it, because the funding is different. Municipalities is one thing, county, so it's a little bit messy. But if you're talking about like just specifically a program,
First responders or police approaches overall.
The police funding is going to be like more than half of just about any major city's budget in the United States. Just to give perspective, I think in funding models, like you asked about, like, is this all volunteer? Like, absolutely not. Like, there's no way that you can do this kind of work on a volunteer basis. I mean, you can, but like that's not a sustainable thing to do. People need to be paid for their labor. There's a lot of labor, like physical labor, emotional labor. And so, obviously, depending on the model, I think there are different kind of pay scales and different ways that those models pay for those services. If you're talking about like nurses and you're talking about like EMTs and it gets a little bit higher. If you're talking about, I think on the social work side, there's different kinds of different certifications that you can have, like same on the medical side. So you can make choices as to like where those grade out, but you definitely want to have a livable wage for people, because what you don't want is the attrition to destabilize the program. As far as like funding, grants, obviously, there's ways to work with federal dollars and that come through the state, and then there's allocation of both like municipal dollars in the health department and public safety dollars. I mean, I think this is a public safety issue. And so I think it sits right at the intersection there. So when we talk about these, the developments of them, like they need injections of cash to get started, but they can be sustained in a variety of ways, and they've been started in a variety of ways. Cahoots in Oregon has been going for over 20 years and started totally grassroots. They did start with volunteers who were just like tired of seeing people at concerts get their heads bashed in because they did too much LSD. So they just took their van out there and hung out, right? And then that ended up blossoming to, a program that is basically the standard. Now, coming from that model, they didn't have the sustainability models in funding, and so they've had to deal with that over time. And integration with, the municipal and county and state apparatus helps to start to manage that. So they're in a transition period right now that they've grown so much, but like how to really sustain it. I think there's a lot of lessons to be learned from across the country, and we're trying to do that, all learn from each other.
I just want to add one little thing about Medicaid. So Medicaid does have some pieces and parcels that can go to mental health crisis response. The trick is your state has to opt in. And where do we live? Ohio. So, no, we don't get Medicaid coverage, but Portland Street Response, Cahoots, like programs that are on the West Coast get like 50% back from Medicaid. Like there are big ways to fund this in a federal way that we are going to be very challenged to access.
Question?
First of all, thank you so much for being here and sharing this with us. For the certified responders, what does their training look like? And do some of the responders have kind of a higher level in understanding mental health, if it ranges?
Yeah, so they're like, for instance, there's different certifications you can get. Like, there's like this peer support, specialist certification. Again, and what Josiah was touching on previously is like how every program has been individualized and tailored to meet the needs and the criteria it needs to meet for like their specific municipality or their specific state. And so like what that would look like for Ohio, because we don't have one, it's still in work. It would obviously have to meet like the the OMAS criteria. But yeah, there is a certain level of certifications that would be required, and that is required in other programs as well, like the CALL program that does have like the peer navigators in St. Petersburg. Like they have to be certified prior to becoming the navigator. Mm-hmm.
Yeah, and I think you can inject like and tailor make it right, like a program. Like you need to go through this training. Like we like this training, we like this training, we like this training, we like this training, and these certifications you need to have, right? But we need you to have these trainings that we choose, because this is what our program is. I think is also another layer of that. So like there's some things that will be certified by the state or whatever, but there's also like these are the parameters of the program. This is the training regimen. This is what it takes to be in this position.
Hey, I'm Neil. I'm a first year. Thank you guys for coming. So as I was listening and hearing about the alternate response teams, like it all sounds pretty intuitive. It sounds like pretty common sense, or it's difficult to think of like really strong counter arguments against it. It seems like a very fair thing, but as I'm saying that, like you could imagine on the other side, and I'm probably going to make some assumptions here, which welcome correction on that, but it would seem like the police would be opposed to this, at least at a broad level, just because they don't want to give up any authority. They would prefer to have more authority. So I guess like thinking about if this were attempted to be codified and the resistance that would come from like a policy level from the strength of the union or whatever else, just as like a practical or as a strategy question, like how would you convince them like of this? Like what would you say?
That sounds like a what did the cops say question for Corey.
That's me. I know what the cops say. So there's two directions of this sort of like that's really sensible. And the first really sensible thing is sending mental health people to mental health calls. Almost everybody is like, that sounds right. The other really sensible thing is that, I don't know if you guys have been reading the headlines, Cleveland can't hire police, right? There's all of these incredible headlines about we don't have the budget, we don't have the ability to bring people into the training to get them to be police, and we can't recruit. And okay, so if we can't recruit police, and half of the calls, and it's more like 75%, I just can't prove it yet because I can't get access to the data yet. But let's assume that at least half of all calls are low-level, non-violent, low-priority, things that we can send non-police responders to. So if you can't hire police, and you can off-board half their work, right? And by the way, it's cheaper to hire mental health professionals and crisis interventionists than it is to hire police officers, right? So there's these two directionalities of very sensible things, and let us not underestimate how bad the police don't want to give up power, right? So I just want to say that really clearly, let us not underestimate that. And there are some really incredible champions for care response who are law enforcement officers. One of the organizations that we work with is Law Enforcement Action Partnership. They are nationwide, and they are a cohort of former chiefs of police, former law directors for the police department, former very high up people from the law enforcement agencies nationwide, and all of them are saying this is the right thing because of those two rungs of sensibility, right? And so the trick is, how do you grind through on a local level in our ecosystem? What does our police department need? And we know that our ecosystem is complicated by the consent decree, complicated by this expansion of co-response. There's all kinds of layers, right? So then it becomes like the onus of each city to stand up their program to say, like, these are our particularities, this is what our stakeholders are comfortable with, and some of that comfort is, what are the police willing to give up? One of the stories we don't tell a lot about Dayton is, like, why is Dayton focusing on nonviolent family dispute calls? It's because that's what the police department was willing to give up. Why is Cincinnati focusing on behavioral health calls? That's what the police department was willing to give up. So you kind of, you carve out a little space, you wrap your arms around it, and you prove the methodology, and then you try to expand. So that's kind of how we get there. But there is, like you said, there's a lot of sensibility to just like, yeah, care response makes sense, right? Like.
Okay, one more question. Wait, one more. Oh, sorry.
Thank you. So because you brought up the Medicaid thing, it goes with the question that I was going to ask beforehand. So what are we doing then in response to our city, our county, and our state governments, and how can they be of assistance in helping in these areas? And I'm from city government. I'm in lieu of someone else. But just curious, because that's what they're going to want to know when I go back and report out. What is it that those agencies can do to help? Because they are responsible for budgeting. They are responsible for making laws. They are responsible for. So what is it that you see practical now that can be helpful? Oh, and I did want to say, only because I was a police officer for 15 years, there is a legality issue with calls that come into 911 and whether they respond. And I think I was at something before and you spoke on that, and not saying that you didn't just now, but I just don't want to walk away feeling like it's just a whole police don't want to give up. There are some legalities. If they call 911, there is a legal responsibility for the police to respond. And so I just wanted, and you mentioned that before when I saw you, so I was like, oh, okay. I just wanted to say that because I do love my sisters and brothers in blue, even though we are lacking in some areas.
Yeah. I'm just going to talk about the DJ. So two of the initial kind of wins that we've gotten already in the ecosystem around care response are, there's a new position in the Department of Health called our crisis strategist. That person's job is to kind of knit together this continuum of care and make sure that all of these programs can be in collaboration so that, that we call it the no wrong door approach. If you raise your hand and say, I'm in crisis, it shouldn't matter whose doorway you're walking in, you should be able to access services that are right for you. And so that's a big piece of important work on the city side that's happening. Another really important piece of city work that's happening is that the city of Cleveland just won a federal BJA grant for the improvement of our dispatch infrastructure, and which is good for all of us. Period. Mark. It's good for every single first responder. Period. Mark. And increasing our flexibility and our capacity for our 911 infrastructure also means that we can develop alternative response that responds to 911. So a lot of the important work to stand up care response looks like ecosystem improvement.
Yeah, absolutely, and that's like great news. And I think being here in a space like this and being able to learn this and being able to get plugged in, folks want to get plugged in, like please do. We can use all hands on deck because there's a lot of education to happen, and that's like person to person, but that's also to people in positions of power who are not familiar with this sort of thing and really have to wrap their heads around that. And that can go a long way in all of these different systems that are going to be having to come together. And I think the real power of this is like de-siloizing our continuum, because if you say this is going to be a front door and it's a traveling front door and it goes everywhere, well then it has to stay connected, and so like that's the job of it, and so that pulls people together. It's that gravity that can pull people together really for a purpose. So I think on the county level, I think there's a lot of funding that goes into health, human services, the criminal justice system. And one of the great things that I love about this is what we call intercept zero, which happens before there is any interaction with law enforcement, right? So this is a non-police response. This is they're not running your warrants, right? They're not, running your plates. They're not doing any of that, right? They're meeting you where you are, assessing a need, and trying to solve a problem. And decoupling that care from the carceral system is just so powerful for our community. And if we can convince the decision makers that is the choice that we should be making, that is what this endeavor really is. And so I really applaud you all for taking the time to come here and honor the legacy of Tanisha. And I'm so honored to be a part of this work and the possibility of the future, without carrying forward so much of the trauma that happens on a daily basis here.
Well, that sounds like a perfect way for us to wrap up. I'll see everybody upstairs in Ben's place for the reception.